Okay, I think we will get started. This is Martin Knapp. I'm going to chair today. So welcome everybody. This is the first of our NIHR SSCR webinars. We're going to have these, we think, every 2 weeks. That's the plan. We normally have them from 1 till 2, but we've changed the timing today because of some previous diary commitments. I'm going to say as little as possible, then we go over to Justine and then to Jill, and there'll be time for some Q&A. So I think what I'm going to do is go straight to Justine now, so we can hear from her about the research she's going to talk about, and then Justine's hoping to spend about 20 minutes and have some time for Q&A, so please get your questions or comments ready for that. So Justine, over to you and share screen.
Thank you, Martin. I will share my screen. It's a great opportunity. I'm delighted to have this opportunity to share a bit about our research. And I'm going to be telling you about this study that we call BOW, Broadening Our Understanding of Good Home Care. I want to tell you a little bit about what we did and why we did it and what we found. And then I'm going to try to encapsulate our results in a simple formulation that might be useful in applications by providers or in recruitment and in training of home care workers, as well as by commissioners, possibly inspectors and researchers in their pursuit of desirable and measurable outcomes when they're evaluating home care. And finally, if there's any time, I think it might be nice to have a brief chat about the implications of the COVID situation and how this is affecting home care in general. The co-researchers on the study are shown on this slide. The field work was done by Samantha and Lucy, who did the participant observation, and Nicola, who did a lot of the interviewing. I'd also like to acknowledge Tony Husband, the cartoonist, who worked closely with us on developing one of the outputs from this study, which is a graphic novel called Winston's World. And the images that I'm going to show you in this presentation are from Tony's cartoon book. Our methods were fivefold. We undertook a survey of local authorities. We did interviews with home carers and their managers. We interviewed relatives and clients of the same 2 home care provider agencies, and about 11 home carers kept a diary for us. But the most substantial part of the research was the participant observation in 7 households over 10 months, which was undertaken by Lucy and Samantha. So why did we want to study home care? Well, social care policy, of course, advocates care in place, and while many young people with disabilities receive home care, we were particularly interested in people with dementia, most of whom are older. It's estimated that people with dementia make up 60% of the 350,000 older people in England who receive home care. And the numbers of home care workers are even larger. There's a high turnover in this workforce. They might number as many as 800,000. And the quality of life of the people who receive home care is really heavily dependent on the quality of the service that these workers provide. So we're very interested in the workers' perspective. And of the, I should have clicked this, yes, of the 10,000 or so providers of home care, many of which organizations are very small, fewer than 6,000 are actually inspected by the CQC. So there's a lot of work which goes on in a black box, if you like. In general, what goes on in a person's home is obviously difficult to study. But we do know that dementia care training for home care workers is far from universal. And this may put people with dementia in receipt of home care at particular risk, especially if they live alone. But we're also interested in the perspective of the home care workers too. We knew from research into healthcare assistants that this kind of job entails a great deal of emotional labour. And arguably, the care workers are also vulnerable because they're working alone in other people's homes. They're vulnerable to accusations or even abuse because there are no witnesses to what goes on in the situation. We knew quite a bit about home care from an organisational perspective. We knew, for example, what factors promote effective home care from the manager's point of view: support for staff, continuity of personnel, staff training in dementia care, and a person-centred, planned and coordinated approach to individual clients. But what we didn't know was much about what home carers do in practice when they're working with people with dementia. And we were interested in how it feels to give and to receive home care. How are the relationships experienced by the care workers and their clients? What are the stresses and rewards of working with people with dementia in home care? In a spirit of appreciative inquiry, we therefore chose to work with a premium provider of home care whose minimum visits were 1 hour, because we knew that many of the variables in home care quality were dependent on the amount of time that workers spend with their clients. What we found, well, we knew quite a bit about what home care workers did. We could judge this from the job descriptions that we examined, from the interviews, and from the field notes of Lucy and Sam, who did the participant observation. This spans the full range of domestic tasks, and in some cases extends into home maintenance, gardening, companionship, administering medication, and almost universally involves keeping records of what they're doing. At this point, I think you should be told that the cartoons we're using do not represent the ideal. They represent the imperfect realities that we observed, and they've been drawn in order to provoke discussion and argument, really. So Daisy, the woman in the red top, is our fictional home care worker, and she's very eager to please. And we know that a good home care worker would try not to say out loud what Daisy says out loud here, because it's, well, it's confrontational, it might be embarrassing, it's highly insensitive. But the reality is that such encounters do occur, and we're using the drawings in our graphic novel to encourage workers to volunteer how to improve a response such as the one that Daisy makes in this scenario. Just to carry on that theme, Daisy's obviously very eager to please, but what she does here is not to promote choice and empowerment for her client Frida. And you'll see in other images that I use that they are open to criticism of the same kind. So we learned from the study that by engaging clients in everyday tasks like eating, washing and dressing, good home carers sought to promote choice, and they saw this as reinforcing the agency and the identity of the person with dementia. In addition, we found that they spent a lot of time and thought, in fact, and planning in order to try to meet the social needs and the emotional needs of clients. This aspect was not reflected in the job descriptions that we reviewed. Still, empathizing with clients and testing out theories about the client's emotional state was an everyday aspect that emerged from the field notes and the diaries that we collected. Again, the image that we offer you here to illustrate this slide deliberately omits that aspect in an attempt to invite learners to contribute their understandings of the emotional aspect of the work. So while essential tasks were generally carried out, it was clear from our research that good home carers do much more. If they had time, they were often very inventive at pleasing and entertaining the clients. Sometimes they did this with the aim of providing mental stimulation for clients with dementia. Sometimes it was to promote social interaction, such as phoning family and friends, or to persuade them to take physical exercise. So meals and personal care served both purposes. So they could be used to foster conversation and sensory engagement, as well as to meet an individual's basic needs. Where time was at a premium, there was much less scope for doubling up, and tasks took precedence. We also found that carers themselves took it deeply personally if a client with dementia did not respond well to their efforts. By contrast, something as simple as a smile from a client could be a rich reward for all their efforts. So we summarized our findings in 4 simple terms that I hope are relatively easy to remember. These 4 key activities convey the essence of the features that for us characterized good quality home care. They're true for home care in general, but they're even more important for people with dementia. First, we found that a good carer anticipates practical needs and manages the environment so that the client is not inconvenienced in these areas. Second, the carer acknowledges the social identity of the client in many different ways, both within the home and beyond it. And sometimes this involves some delicate, diplomatic interactions with neighbours and with relatives, where the wishes of the client came into conflict with other people's wishes. Care workers, home care workers, were often very skilled at diffusing conflict or avoiding it altogether. Third, the word here is attunement. We found that a good home carer was versed in and attuned to the sensibilities of their clients. They understood their habits and their preferences, and this enabled the home carer to deliver support in a manner that satisfied that individual, even when that individual could not express their wishes articulately themselves. And finally, the good dementia carer afforded the client opportunities for pleasure and for agency within the scope of the caring role, often with the aim of encouraging physical and mental activity or social engagement. Clearly, these 4 activities demand a range of intellectual and organizational skills, together with a high level of emotional intelligence, both of which make the job challenging and immensely satisfying. And I often liken the role of a dementia home carer to that of a high-powered executive secretary or personal assistant, even although the pay is hardly comparable. In this table, I've attempted to relate the activities to specific skills and knowledge. It indicates what sort of features, characteristics, and experiences we might be looking for in a good dementia home carer, or looking to develop in a good dementia home carer. Of course, we haven't tested this out, but it's open to further development. That sums up our research findings. This is where you will find copies of the graphic novel, which has got 90 wonderful drawings by Tony Husband and 5 typical scenarios that are intended to provide a platform for training and development of home care workers. These are the main papers from the study. And I don't know how we're fixed for time. Oh, that's my disclaimer. Thank you very much to SSCR for the funding for this study. I wondered if you feel like discussing the impact of COVID. I picked up on this paper which proposes some changes that it's bringing about on home care, increasing costs, reducing demand possibly, increasing local authority budget restrictions, and maybe in the longer term, a growing demand. But that's all from me. Over to you, Martin.
Okay, thank you very much, Justine. That was great. Very interesting, very well illustrated, and perfect timing. So over to the rest of you, and there are 50 of you, or there are 50 of us, which is great. So would anybody like to ask a question? Yes?
Right. I was just wondering, Justine, if you're aware of the NIDUS project, NIDUS, which is based at UCL. Have you got any links with that?
Hello, Sandra. It's lovely to see you. Yeah, I did in the early days talk to the researchers on NIDUS. I have to admit I've lost track over the last 12 months or so, but it would be time to renew that contact.
They're in the middle of developing materials to train home care workers for people with dementia. Great,
I'm glad to hear it.
Okay, other questions or comments, please just... Okay, Margaret, I can see you waving. Yep.
Yeah, thank you. The issue you mentioned that I think it was £25 an hour, so it's a premium rate.
I've just checked up on the recommended rates by the UK Home Care Association, and I think they're between £20 and £21 an hour. Yeah. But even that is higher than most local authorities will pay.
Well, exactly. I'm coming from the viewpoint of personal experience in my case. I'm involved with a charity that I'm a trustee of a charity that provides home care at that rate. And it is paid for by the local authority occasionally for people with very complex needs. But I've also had experience of being a self-funder, and that's quite a high rate that either the self-funder has to pay or the local authority. So in a way, you're looking at a premium service. And I know from experience that when you enter into a contract with the care provider, you draw up an agreement about what will be covered. So whether it's just the activities of daily living in relation to personal care, or if it involves shopping or whatever. So in a way, you have a certain barrier right at the beginning, because once the contract is agreed, and that could be with the family or the local authority, then the care worker really can't, for all sorts of risk reasons, etc., which you will recognise, go beyond those boundaries. So you're looking at a very comprehensive approach, what it should be, obviously in ideal situations, but a lot of people with dementia, and I'm living within that environment really because I'm in touch with carers every day. You know, it's very dependent on the quality of care that is enabled through the contract right at the beginning. So, you know, it's not a criticism at all, but it's an issue of looking at the research in relation to what actually happens on the ground, where people are really receiving the minimal, you know, basic care.
Yeah.
Very
Sorry, you're absolutely right. I don't disagree with anything that you've said, but the reason for undertaking our study on such a small scale, but with appreciative inquiry in depth, so that we could get a clearer picture of what good home care looks like. Yeah. That was the research question, and that is, I hope, something that we've illuminated, which can guide planning and purchasing and training in future.
Totally understand, yeah.
Okay, I think Mark and then Liz.
Sorry, Liz, I got in there before, very quick. I was wondering, Justine, if you could say a little bit more about the fact that some care workers, that when they found some of the negative aspects, they took it quite personally, and that was quite a telling sort of cartoon that was shown as well. I wonder if you could say a little bit more about that, please.
Well, I think it touches on the whole subject of emotional labour and how people take home the feelings that are generated at work, and how people live with those kind of experiences outside of the workplace. It's not exclusive to home care, it's a feature of a lot of social and healthcare work, of course. And I guess it can be governed to some extent by good management and supervision. Well, I'm sure it can be supported by good management and supervision, but it seems to be part and parcel of the role, albeit an aspect that is not remunerated, really.
Okay, Liz, do you want to?
Yeah, it's just a really simple technical question. You said quite early on that there were 10,000 providers, but only 6,000 that were regulated. I wondered, who are the other 4,000?
They're small providers with 1 or 2 or 3 clients, and they're the providers who don't provide personal care.
Right. The old inspector in me was kicking in and thinking, even if they've only got 1 customer, they should still be regulated if they're
I think that's not the case,
personal
definitely.
care. Thank you.
Okay, other questions or comments? I have one to chip in. So you, towards the end, Justine, you were giving us you didn't say the 4 A's, but we picked it up. We're clever students. So the anticipates, acknowledge, etc. Is that something you're thinking about in testing? I mean, having said these are what you identify as good practices of home care, do you think this is based upon a particular research design, and you've developed it as you've gone through? What's the next step?
I think we're offering it really for people to dispute, I guess. I don't have a particular plan for testing it. Have you got any proposals there? I mean, I don't really know how we
I'll talk to
do it.
offline. It's intellectual property. Be careful about that. No, I don't.
Yeah.
But I think it's. I mean, it seems to lend itself. It seems that it is a very interesting and careful developmental way to identify what might be seen as constituting good home care. So that seems, and I like the way you've done this in lots of respects. But I think then the next step would be so let's put this to a wider test, and it goes back to some extent to what Margaret said about then looking. You've done exactly what you said you would do in the study, but then looking at other home care providers that don't charge premium rates, and then seeing what this might look like in that context would be interesting. So
yeah, I should talk to NIHR as well, I think.
Okay, we've got time for one more question, I think. So Mike, I think, before.
Thank you, Martin. Thank you, Justine. That was really interesting as ever. I guess following on a little bit from that, it would be about taking that framework and seeing how it scales into different contexts of care, whether it be shorter visits or less premium priced visits. But also you mentioned COVID, and I guess there's an interesting article on the Guardian website where a GP in, I think it's Edinburgh, is discussing how basically in his practice he has thrown into the air all of the lessons about communication with patients that he's learned throughout his whole career, and now he's having to adapt. And I guess ultimately we might all have a bit of space to reflect on, what real difference and impact that has made in the longer term. But I guess that could be another aspect of this, seeing how colleagues that are delivering home care adapt their practice around that framework in a different delivery context of keeping social distance, at least that they haven't got any protective equipment to get in the way of the interaction, I suppose. Maybe that's one small blessing there.
I have to differ with you there, Mike. The home carers I know are using PPE.
Okay, I guess I'm just going off the news where people are saying that lots of them are still not getting the PPE. But anyway, that would be another aspect to look at.
Yeah, absolutely.
Okay, I think we're going to stop there. So I'm going to say A couple of things. First of all, thank you very much, Justine, for giving us those insights into that SSCR project. Really interesting indeed, and thank you for being the first one in our series. So that's brilliant. Thank you. And the slides, Angie or Susanna will tell me later. I mean, this is recorded, as we said we would do with these webinars, so they'll be on the website, so people then go and could check to get more information if they want to on the various citations you gave and so on. So thank you very much indeed for that. And let's all do a virtual clap. You can bang your desk or whatever you like at home. And yes, that's a good point, Dave. We can do it that way. We do the good. Okay, so we're going to hand over to Jill Manthorpe, and just straight over to you, Jill, and you can do your own introduction and get cracking as you like.
Right. Thanks, Martin. And I hope you're still talking, because I've put my screen up and I can never tell whether anybody can see it. So if you can just say whether that's okay.
It is okay.
Great, lovely, lovely. So this is a project, which isn't a project, it's a methods review. But that was commissioned by School for Social Care Research as a series of reviews about methodology, particularly germane to social care. And the one that Kritika and myself opted to do was about interviewing people with dementia, largely because I think we thought that it was timely to think about this in relation to social care research, rather than the great body of evidence around interviewing people with dementia that is very much health focused and concentrates, for example, on things like early diagnosis, concentrates on communication in surgeries in hospitals and so on. But actually, when you come down to it, there have been few and far between studies that have really addressed interviewing people with dementia about social care, although many of such interviews in other settings in other contexts were set in social care settings. So that's why we wanted to look about the subject of interviewing people with dementia in relation to social care, not only about social care, but also to say, what can we learn to improve social care for people with dementia, who are a sizable proportion of social care users, but also to think about other groups that might be applicable to, because people with dementia don't just generally have dementia, they have a lot of other conditions as well. So I'm going to be presenting a summary of this. Kritika apologises, she's got another commitment this afternoon, but we've worked on these slides together and we hope they're of interest to people. And we'll do the link to the methods review at the end if people haven't read it. It's great to see so many people I know and other people I don't on this webinar. 50 is a great number, so welcome to everybody. Good, here we are. So going back to basics, as people might say, we wanted to really think about what an interview was designed to do. And Justine's research clearly showed us there were many ways to hear and see and observe people with dementia in receipt of home care. She talked about observation, she talked about diary, data collection with the home care workers and so on. But we thought it helpful to think that an interview is deemed to be by researchers as a conversation with a purpose. And of course, when you talk about purpose and you talk about intent and you talk about conversations being two-way, you get into slightly muddy territory when we're talking about people for whom communication is not as easy as perhaps it was in the past. But generally, we went with this nearly 100-year-old definition, a conversation with a purpose. And here we are with our own set of cartoons saying how these sometimes go. And we think it's an important way to collect information, hearing individual perspectives, and also gathering stories. And stories we think are coming out through interviews now is perhaps much more part of the narrative approach, rather than just presenting them in factual ways or pulling together interviews into quantitative data. So in this presentation, we're going to be thinking about the value of conducting qualitative interviews with people living with dementia in social care research, not just in social care settings, and covering these 4 bullet points. And of course, our methods review is linked here if people haven't had a chance to read and inwardly digest it all. So we pulled together some of the reasons why people were interviewed in research related to social care, because of course there were many other options, perhaps such as observation, such as interviewing proxies and so on and so forth. So these seem to be our key motivators. First of all, in social care research, there is great interest from practitioners and commissioners about hearing the views of people with dementia. They often, I think, feel rather distant from them, and practitioners often talk about the ways in which short engagement, even if it's strength-based practice or so on, really doesn't help them in getting a picture about how people are experiencing services, how people are experiencing services in the context of their wider lives, and so on and so forth. And commissioners too, who spend a great deal of their budgets on dementia services, often I think feel that they don't hear from service users with dementia as much as they do from other groups. The second motivator, I think, is probably more around research, but it certainly has influenced practice, which is around the biomedical model of dementia has been challenged for nearly 50 years now. Kitwood and colleagues around that time, talking about it isn't just about symptoms and about burden and about neuropsychiatric inventory scores and so on, but enabling us to hear and often touch on quite sensitively the real issues that people with dementia are facing. And interviews may be some way of perhaps hearing the emotional and the psychosocial parts of dementia. Which of course links to the ways in which biopsychosocial models of dementia are now being construed, in that as well as for people interviewing people with dementia as if they were a homogeneous group, we're now quite interested in perhaps the different causations of their dementia, the different stages or symptoms that are associated with it, and how people are individually responding to them. Moving on to a fourth, sorry, too eager to press on. Moving to others, quite a lot of information, I think, in relation to interviews and in dementia sphere comes from our colleagues in Scotland. Not all of us, I know, are an English audience, but in particular, we've listened to a number of groups led by people with dementia, or in which people with dementia have been greatly engaged. I think starting initially with the work of Mary Marshall, whose social care and social work background was a strong influence, to say that people should be more than a silent presence in interviews about dementia or in talking about dementia and service use. And then we touch on the bit about interviewing people living with dementia as important. And when thinking about the different forms and the severity of dementia symptoms, these aren't the only determinants, but as our methods review comments, probably there's been greater interest in people, and not surprisingly, in people with mild symptoms of dementia. Again, a lot of them not receiving social care because of needs and means testing eligibility, but noting that this isn't the only determinant. And then lastly, a little bit of evidence now that interviews can be safe for people. They offer a safe context in which people aren't exposed by having to fill in questionnaires or respond to services. So just touching on the guiding principles, we've discussed those into 4 main areas, and you can read all about them in greater detail in the methods review. We know that people who are wanting to do interviews with people living with dementia are probably going to be told time and time again that there are problems, or to use the more favoured word, challenges in talking to people with dementia, or even getting access to them. How these are mitigated is done in several ways, and I think Justine talked about ways in which her research team shadowed care workers and therefore became quite trusted. This has been done in other contexts as well, around social care, such as being familiar faces in day centres, or perhaps joining in staff teams within care homes and offering activities to mitigate the challenges of being strangers, to perhaps producing distressed behaviour among people as strangers, or perhaps people who people are fearful of, perhaps mitigating potential challenges around language, and a whole range of ways in which turning things into easily digestible questions or perhaps listening opportunities is very important. We draw on a lot of material related to language and speech, which will be very familiar, I think, particularly for people with practice experience around not using hypothetical situations, not offering an enormous menu of choices, reframing language, perhaps using techniques that sometimes people have found increasingly valuable, such as talking mats. And we do a section in the guide on the uses and the evidence for talking mats, which I know has been, I've been aware of being around for a very long time. And it's interesting to see that they're now talking about using with people with dementia, but also learning disabilities. But the ways in which pictorial language may make sense to individuals. But to be careful about language and to be careful about speech, particularly in social care, which is so replete with jargon, as everybody knows, that we tend to think about assessments and reviews and monitoring off the top. They trip off our tongues, don't they? But for individuals, as we've known for many years, to be talking about assessment is quite fearful, fear-provoking. Then there's the question about whose voice. This lies in respect to dual interviews, which I think are increasingly common among people with dementia living at home with other parties. There is a deal of concern among relatives that a researcher may hear a particular perspective from the person living with dementia that doesn't entirely accord with their own version of reality. And those people who are social workers will know that good practice often involves getting hold of several informants in order to test out somebody's pretty firm assertions that they can manage okay, they can cook a Sunday lunch, and so on and so forth, when the evidence in front of your eyes is slightly different. So it's thinking about voices, whether they're relatives, whether they're care workers indeed, or whether they're perhaps people who might be advocates. There is actually very little evidence about the use of advocates in social care research, as perhaps using them as intermediaries and so on. And it would be useful to think about ways in which advocates might be able to assist there if they've been able to build up a relationship with people. And the new Mental Capacity Amendment Act may well help us think around the greater role for people who are going to be replacing best interest assessors by being pretty much the approved mental capacity professionals who'll be working with people who've got very complex situations where decision making is pretty difficult for all concerned. Then lastly, we talked about insight, and drew on quite a lot of the psychological material to talk about whether or not people with dementia have insight, what is the role of their symptoms in perhaps increasing their trust in people, increasing their ideas, minimizing their insight into their own condition or the situation of others, perhaps not having insight into risks and so on. And helpfully, now the psychological literature offers some good ways forward to think about insight, particularly I think if challenged by an ethics committee about that topic. Moving to ethics, you'll know that the Mental Capacity Act talked about principles about choosing and consenting to participate in a research study, and usefully says that if you can get the information in other ways, don't bother participants. And that applies to people lacking capacity for a whole range of reasons, but particularly for dementia. I can think of few studies where actually they've been refused on the grounds that you could probably get that information elsewhere, but I'm sure there are some lurking around. The Mental Capacity Act Code of Practice has been particularly useful, I think, to us all, that we've quoted in codes of, in applications to Ethics Committee and indeed applications to research. You're probably all aware that applicable to England and Wales as it is, it's currently being revised and is due to come out this September, October. We're not entirely sure about whether or not it will come out those dates, but because the Act actually was passed and enacted, the MCA Amendment Act, that's reforming DOLS, the Deprivation of Liberty Safeguards, it does need a code of practice. So it may be that that does come through in a civil servant term of autumn. Here, I think, are the areas that we touch on in a little bit more detail about in our methods guide, which is about obtaining consent and maintaining consent, using Dewing's earlier development of process consent, making sure that it complements the MCA Code of Practice, new and old. It is, of course, widely used in research, as I'm sure many people know. So let's talk about the interview process, and I'll just have a look at the time. Good. So, fundamental. Are interviews the best way to answer our research question? Yes, I think that perhaps is often underdeveloped, isn't it? Because if we want to ask people if they're getting a service, probably interviewing them is not the best way to do it. But interviewing may work about how they find the service and what they think of the individual and the process, and indeed how they're conceptualizing outcomes. We talk in the methods review about the types of questions that experience has shown work. Probing questions, being sensitive about the depth and the challenge that they might suggest. Also the types of questions that perhaps would produce only a negative answer or only a positive answer, or might be seen to be very intrusive, and particularly run the risk of traumatizing people or re-traumatizing them. Questions, as everybody knows, can be open-ended, closed questions. We make a cautionary point about avoiding double questions and multiple choice questions. That really is, I suppose, the people who often have the tendency to translate a survey into an interview and think that things will work well. It probably won't. And I think it's it's always been very useful in looking at quite a number of clinical studies to see how many questions were not answered by the time you got to about 3/4 of an hour through a great deal of great detailed survey, and people, almost everybody's given up the will to live by the number of times you've asked people how difficult things are. We've talked also about developing interview topic guides and the way in which this needs to have people, a great deal of voices involved in those, that what will appear perfectly logical, what will appear perfectly simple, just won't be to other people who are not in the jargon. When we talk about an agency, for example, as we do in health and social care quite a lot, your agency worker or something, almost meaningless to members of the public, and perhaps in dementia even more so, because terms are confusing to start with, and perhaps the question you're setting up people's fearing to fail, perhaps, by not understanding what we have said. We've also mentioned about sample size decisions, the numbers and groups. A great deal, I think, now of pressure to get larger sample sizes, and in particular so that you can say that these are representative of absolutely everybody, every rurality, urban, you name it, every Equality Act characteristic and more so. The sample size, it takes a brave person to say that interviews were saturated. I too find that very difficult to say sometimes, that by about number 18 of the interviews we are in some studies we find we are repeating, that responses are very repetitive. It's important, I think, to stop, partly because we are troubling people's lives and often their families or their care providers by intruding into their own lives. But of course, we also want to just hear from a few more people to make it more representative. So sample size decisions are important, if not governed by, of course, our own resources and costings. So we've touched on a little bit of these, but just to go over again, and I will mention the COVID context in particular. Access and recruitment are not easy, and people might have seen an article by James Fletcher recently, where he was turned down by an ethics committee because he wanted to access older people and ask them about dementia on the street. And he was refused to do that. He had to go through third-party organisations. So access does have its challenges, and there are many agencies which perhaps are slightly more accessed than others. I'm sure we can all think of our favourite care provider agencies or our social clubs and so forth, and perhaps overuse them. But the reason why they're favoured is that they are quite nice to researchers. And indeed, we're benefiting a little bit, I think, now from the CQC, the Care Quality Commission's views that registered care providers should be research active, as in allowing people to research in their services, not themselves doing research. So we're pushing perhaps at an open door. Recruitment, and if this wasn't the COVID context, I would draw people's attention to the ways in which the CRN and the National Institute for Health Research research networks are supposed to be helping us with recruitment if we're NIHR funded. That's stopped at the moment, but we have great hopes that this will be a productive relationship in the past. We need, of course, to set the context when doing the interviews. Describing something like a day centre might sound as though we all understand what a day centre is, but it could be an afternoon in a church hall, or a fully funded health and social care resource centre in the middle of a pretty smart other resource centre or something like that. So setting the context, it's important, but also orientating the participants, which may need doing a few times during the conversation. We do find it important to acknowledge people's anxieties about interviews, particularly in social care research, because of the fear that if people say something negative, then the service might be stopped, for example, or curtailed. We know that we don't have too much sense that people with dementia are thinking that, but certainly there are many reports that people who are carers feel that if they say something, then the service might be terminated. Building rapport is easily said, but involves perhaps a greater use of the self than takes place in many interviews. And of course, communicating effectively is the $50 million question. We took really quite a good I think summary of these strategies. We could probably all have developed a similar strategy table, but these particularly relate to the possible effects of dementia, which are about attention and concentration lapses, and people, in a sense, people falling asleep during an interview, which I'm sure is people's experience in a whole number of studies. So conducting interviews in a familiar place, certainly not in a clinical office or so on, though sometimes people do like to get out and go to places. Redirecting the conversations if possible, but again, allowing them to flow if it perhaps appears really meaningful for the person to tell you their story. Decreased abstract reasoning, so less of the hypothetical questions. If this didn't happen, what would you think? Supposing this happened, and so on. Using participants' wording that's familiar and comfortable for them. Carers, care workers is always confusing, isn't it, the term, but people often do talk about carers, and you've gone quite a far down the conversation before you realise that they're talking about a home care worker, or on the other hand, you realise that they're talking about a family carer. So thinking about people's wording, and of course people will often use things like the welfare, and it takes some probing to work out what on earth that means in today's context. So difficulty with word finding, not always symptomatic of dementia, but symptomatic of other conditions as well. So about giving time, reassurance, help, not just jumping in immediately, but sometimes perhaps offering situations. Memory loss, clearly one of the key symptoms of many dementias, about using reminiscence, providing clues and cues, such as photographs, for example. Very helpful when we're talking about individuals or talking about people in certain uniforms or colours, something like that. Not everybody in social care wears a uniform, but quite a large number do. Repeating phrases or dwelling on a topic, this may be difficult for people. Perhaps they're trying to tell you something about loss or what's meaning for them, but perhaps it's also important to redirect the conversation or appropriate. And then, of course, lots of interview participants can get fatigued, and we need to be careful about that and stop, maybe restart, sometimes go back, and sometimes just not go back. So what can be helpful? We'd link this in 4 particular ways about joint interviews with carers. Problematic, of course, because carers may be protective, carers may have different views, but sometimes that is the only alternative. Using interview aids, such as signs or pictorial representations, verbal cues, touched on that before. Using vignettes very carefully, possibly for people with slightly earlier dementia. If a person was in a situation such as this, what do you think they might be thinking? Effectively used by some people with mild cognitive impairment in particular. And then lastly, I talked about talking mats as being one way in which we can perhaps get people's views when their communication problems are really quite advanced about whether they like something or not like. And those mainly are developed from our learning disability work, going back to Tizard and all that, and a whole host of things. So just moving on then, 3 methodological considerations. The use and the involvement of people with living with dementia as co-researchers or peer researchers, often advocated, I think, again, more by our Scottish colleagues than our experiences in England, but I do know that there are a few English studies where this has happened. Perhaps not doing research interviews themselves, but being able to be involved in the analysis, teasing out what seems important to people, and there's a section in the guide on that. Then working with people who are living with dementia, who've been writing firsthand about their lives. Wendy Mitchell springs to mind, but there are others, and we quote James McNamara in particular in our guide. Not so that we can use those as interview data, but so that we get a sense of how that feels to an individual. One of the problems, though, is that often such individuals are not receiving social care services, although that may change in the future. Thoughtful analysis and writing up of findings to describe and present the full picture, and a very useful study from our health service colleagues refers to the tendency to find the brilliant quotes from people in which everybody appears very, very cognitively able and uses beautiful metaphors or allusions, whereas in reality, when you look at some of the transcripts, often perhaps responses have been limited, sometimes monosyllables and so on. So really being fair to the interview data itself. Just winding up then to think about the COVID context. Interviews with people with dementia in the current context are going to be difficult. It's hard enough for a home care person to be talking to an individual or a care home worker. Social distancing, shielding and lockdown are part and parcel of the experiences of people's lives with dementia, because also they often have many other problems, and of their carers as well. We anticipate that these curtailments are going to persist for vulnerable groups and the places in which they live, particularly in care homes. I think there are very few care homes who see themselves as opening their doors for quite a time, and the ways in which they do it may be that researchers are not the first in the queue to go in. Research questions and methods are going to need very special planning and justification about troubling people, possibly re-traumatizing them, or just even getting access to individuals when there are other important communications they need to have with families and friends. It may be that we then turn to greater reliance on our informants, and surely there's room for methodological development here, rather than to have that truism of saying, well, carers often talk as carers and can't really respond. How can we develop a method that perhaps says that informants are useful, they may be partial, and indeed this is how we can interpret what they say with another eye? And I think that's something that we'd like to take forward. We do need to talk about the risks of re-traumatizing people in distress, about talking about this particular experience, which may be very fresh in their minds if it's face-to-face, but also doing this by telephone and virtually. We're not going to be there to pick up the pieces, and maybe nobody else is either. Last point relates to the value of reanalyzing data. I'm probably as poor on this as anybody else, but very few people reanalyze data, I think, in social care research, and most of us, I'm ashamed to say, don't always archive it. Here's a list of useful resources, as I've mentioned, and lastly, here is main resources for some of the key documents I've put here, and a thank you from Critica and myself.
Good, thank you very much indeed, Jill. Thank you. So we've got very few minutes, but let me see if I can get to see who's, oh, I've lost you now. So anybody want to make a comment or question? Okay, Catherine and then Sandra. So Catherine first.
Thanks, Jill. That's absolutely fascinating. Could you just say a little bit more about the taking of consent and how that process works?
Well, before COVID, we were all doing this face-to-face. But I think particularly in care settings, there has been mediation of that by individuals such as care home managers telling us about the, people who they think are able to give consent. And that's been, most researchers have taken that forward, that they don't want to trouble people who are at the end of their life or who are very distressed and so on. So we touch on that about consent, seeing it as a staged process, and then during the interview making sure that people are still happy to be involved there. So have a look at that section in particular.
Okay, Sandra?
Wondering if you'd heard about the group of people, I think they stem from DEEP, you know, the group DEEP,
Yes.
who are doing their own research now. They're selecting their own research topics. And I've also heard that academics can put topics to them and they'll consider whether they would be co-researchers or peer researchers in that kind of setting.
Yes, as you'll see from the, I think almost the penultimate side, we've linked DEEP's works there. They have got some ongoing work which we hoped would be ready to include in that publication that I mentioned, but links to their website are there, and I think they're going to be really helpful. There is a caveat though for social care research in that not so many of the individuals concerned have social care experience, and so I think for health service researchers, it's really interesting. But those of us who really got that social care focus, individuals are often very near end of life, often have profound communication disabilities, and indeed are very protected by the individuals supporting them. So I think we have to, in social care research, make it quite clear that sometimes social care is a little bit different.
Okay.
Okay, time for one more comment or question. Or not. Okay, I'm going to just say a few words just to firstly thank Jill for that excellent presentation, and as Jill showed at the end, there's a method review which was published in the last couple of weeks on the SSCR website, and will make very good presents to send to people during lockdown. So that's available for more detail. Thank you, Justine, as well for the presentation you gave, and this has been the first of the fortnightly webinars. We're sorting out exactly who's presenting in a couple of weeks' time. It'll be at 1 till 2. I want to thank Susanna and Angie for getting this together, and actually everybody's been very well behaved. We're so well trained in Zoom now. I think we're getting very good, so that was great. And we'd love to hear from you if you've got suggestions for what we do in terms of how we organize these sessions, what presentations to do, and so on. Please do contact us at the school, and I just want to thank you all for participating. It's been really helpful from our point of view to have you listen to what we do. So thank you very much, and have a safe and healthy afternoon and rest of the week. Thank you. Bye.
Thank you. It's been great to see people. Thank you.